This is my oxygen delivery Osces. Oxygen is contained in a white cylinder. It usually has a paper tag on the side which labels it as oxygen and whether it is full, in use or empty. The regulator has a Botox seal which ensures a tight seal, and this can leak due to the breakdown of the seal, and should be replaced when necessary. The regulator has 3 prongs which need to be lined up with the holes on the oxygen wheel. This should be tightened using the screw on the side, and needs to be finger tight. On the regulator is a pressure gauge which indicates how much oxygen is inside the cylinder. 2000 psi indicates a full cylinder. Okay, as this is a high pressure cylinder and contains a flammable gas, safety considerations include lying this flat on the ground and should only be used in well ventilated areas and kept away from flame. You should also avoid contact with oil, grease and lubricants. Indications for oxygen use include SpO2 levels of below 94%, airway obstruction, respiratory distress, shock, being unable to obey commands, such as with a traumatic brain injury, carbon monoxide poisoning, smoke inhalation, and decompression illness. Caution should be taken for patients who are morbidly obese, are on home oxygen or have CORD, as these patients should usually be kept at oxygen saturations of between 88 and 92%. There are several delivery devices dependent on the volume required and the use of nebulized medications. You should always use the simplest device and at the lowest appropriate flow rate. For this presentation, we'll be using nasal prongs, which deliver 24% oxygen and should be used at between 1 and 4 litres per minute. To use the nasal prongs, you first need to attach the tubing to the nipple on the side of the cylinder. This should be then turned on using the dial at the top and set to the appropriate flow rate. I'll be using 1 litre per minute. This needs to be turned on before placing it on the patient. Okay, so the nasal prongs need to be placed inside the nostrils of the patient, and then the tubing goes over the ears. When you finish using it, you take the tubing off the ears, out of the nostrils, and turn the cylinder off, bleed the regulator, and remove the tubing, and then unscrew the regulator from the cylinder. Before I use the medium, I'm going to check for any leaks. First in the reservoir bag, attach that to the end and pump it up. Get this pumps up okay. Then attach that to the correct end. Then I want to check the medium itself. So I want to include the hole and squeeze. That's fine. Then I'm going to attach the mask on. Mask seal. Before using a medium, you should always insert an OPA or an EPA. In this case, I'm going to use an OPA. To use the medium, I want to attach the oxygen to the end of the medium and place the mask over the patient's mouth and nose and perform a head tilt chin lift. When I squeeze the bag,
this is my suction Osces. For this demonstration, I'll be using the louder suction unit.
Before using, I need to first test that it's working. For this, I include the tube and also ensuring that it makes it up to at least 300 milliliters of mercury. To use this on a patient, I need to ensure the patient is in a lateral position or the recovery position. So that has passed. Now I need to check that the suction is working. To do this, I will include the hole and feel the end to make sure it is working. The normal systolic range is between 110 and 140, and the normal diastolic is between 70 and 90 milliliters of mercury. So when a patient has an abnormal blood pressure, you'd usually talk to the patient about whether this is normal. So Grace, is this normal for you?
Yes.
And this is going to involve going and putting a stethoscope on your collar and up your shirt a little bit on the front and back. Is this okay with you? Yeah. Okay, and I'll just warn you, it's a little bit cold. Okay.
For the scenario, my patient has a laceration to her medial on the radius. Using clinical judgment, I have identified that the appropriate control mechanism for this injury is a tourniquet. So, Evie, are you okay if I apply this tourniquet? Yep. Okay. So, we slide this up the arm. It's important that the tourniquet is at least 10 centimetres proximal to the injury and also needs to be applied on a single bone, in this case the humerus. So we tighten the tourniquet and it doesn't need to be too tight, as we can also use the windlass to further tighten this. To do so, we turn the windlass and secure in place using the D. Once this is done, is no longer present. Yep. Had this not been successful, we can apply a second tourniquet proximal to the first. We also need to make sure we write on the tourniquet the time and date that it was applied.
This is my C-collar Osces. When deciding whether or not to use a C-collar, I use the Nexus criterion, which is a posterior midline C-spine tenderness on palpation, a painful distracting injury, evidence of intoxication, neurological deficit, numbness or tingling in the fingers or toes, or an altered mental status. I use these alongside the Canadian C-spine rule and our own clinical judgment. Before applying a collar, I first need to gain consent, and as I do this, I will explain the procedure to the patient. As my patient is unconscious and therefore has an altered mental status, consent is implied, although I will still continue to explain the procedure to them in case they can hear me or if they wake up during the procedure. The first thing I need to do is get my offsider to secure the head. So can you do that please for me, Grace? And so Grace, I'd like you to do that for the entire procedure. So the next thing I need to do is measure the patient's neck and line this up with the collar. So I do this with my fingers. So the patient's neck is 4 of my fingers, so I'll line this up with the collar, and this comes up to the no neck mark. I'll get my offsider to continue holding the patient's head until we have the patient on a stretcher and can pack around the head, or until they're at the hospital. This is my fracture management Osces. For this, my patient has a suspected left tibial fracture. So first I want to explain the procedure to the patient, as well as gaining consent to treat them. Next I'm going to expose both legs, as well as pushing the buttons here tells me how much battery. The appropriate dose for this is 3 mils at any. To turn it on, I push the on button up here, and I want to turn this into manual mode. So I will push energy select, turn the dial to yes, and push it into select. I want to change this down to 50 joules, and select. Next I want to run a user test. To do this I push options and turn the dial to user test and select. While it's doing that, I'm going to go through the pockets because it'll take a while. In this pocket here, we have the non-invasive blood pressure cuff, which is controlled by the NIBP button here. We also have end-tidal CO2, which attaches in here. I push it in and turn. I won't attach that now, as it will be loud. We also have the SpO2 probe, which I've got attached now to my patient, as well as the 3 leads. In the back, we've got some spare paper, should our printing paper need changing. In this pocket here, we have a defib attachment, as well as a test load, 12 leads. We also have a razor, GTN and aspirin, as well as in-date defib pads. Okay, so the user test has passed. I'll show you how to deliver a manual shock. To do this, we have the test load attached. Push the charge button. When that tells it to, we'll push the shock button, and shock has been delivered. Should I choose to
Sound of bones.
push in the dial, and this will disarm. I could also do that at any point while it's charged, so I've got to be aware of this. Next, I'm going to assess neurological and cardiovascular integrity. So to do this, I'm going to check their pedal pulses, as well as check for sensation, ensuring this is the same on both sides, their cap refill, and ensure that the temperature is the same on both sides. And now that I've done this, I'm going to choose the correct splint, and I'm going to pad this with a towel for comfort. I want to ensure that my splint is long enough to go both on either sides of the wound. I'm going to get my partner to assist me with this by lifting out the leg as I put the splint in place. So on ready, set, lift, I want you to lift, please. Okay, ready, set, lift. Assessing for any dangers to myself, my offsider, or my patient. Hello sir, can you hear me? No response to voice, no response to voice, no response to pain, checking the airway. This is my vital signs OSCE. For the purpose of this video, I will only be doing 3 of the vital signs, as well as auscultating for a respiratory assessment. 81 to comms.
Copy.
Confirming an R49, requesting R50.
Copy. Backup's 15 minutes away.
Thank you. I'm doing right-handed. Just keep going and I'll work around you.
Analyzing heart rhythm.
Analyzing patient, please
Do
stay
not
clear.
touch the patient.
So in this 15 seconds, I counted 17 beats, multiplied by 4 is 68 beats per minute. This is within normal adult range of 50 to 100 beats per minute. Next I'm going to take a blood, and had there been any witnesses, I would be asking for a history. Okay, Hannah, can you please count out loud from 25? It's important to ensure that I deflate the cuff while I'm getting myself ready, so that I don't cut off her circulation for too long. I'm going to place the stethoscope on Grace's brachial pulse. So I heard Grace's blood pressure start at 90. millimeters of mercury, so that this is her systolic pressure. I could no longer hear it at 60 millimeters of mercury, so this is her diastolic. So now, Grace, I'd like to do a respiratory assessment. So this will involve auscultating Grace's chest and listening to each of the lobes. So Grace, if you're okay with this, I'd like to listen to your chest. Okay. So while doing this, I was assessing for volume clarity, and Grace's air entry is equal and clear. I also counted Grace's respiratory rate, and I counted 3 breaths in 10 seconds. So I multiply this by 6 to get 18 breaths per minute. It's important to try and do this without telling the patient, as this can cause the patient to subconsciously alter their breathing. And that completes my vitals. This is my basic hemorrhage control oscilloscope. So the first thing I need to do is I need to expose the wound. So Manisha, can I please have a look at your arm? Alright, so I've exposed the wound, now I want to irrigate it. So Manisha, can I wash and dress your wound? Okay. So I want to irrigate it using saline, and I can also use a gauze strip wet with some saline to wipe away from this. Then next I'm going to fold up a gauze dressing to the size of the wound and apply pressure like this. And I'll get Manisha to hold that there for me, thank you. Then I want to wrap this up with a bandage, trying to keep this nice and tight to apply good pressure. As I cross over the wound site, I want to twist my bandage to apply greater pressure. Had the wound been deeper, I could have also packed this with bandages or other dressings. So now I've come to the end of that. I want to tuck that in to keep it nice and secure, and then I want to assess for peripheral circulation. So to do this, I'm going to check both hands to ensure they are equal. So checking for cat refill. Cat refill is good. Her hands are warm, the colour is the same, and Manisha, does that feel the same on both sides? Fantastic. I could also apply indirect pressure by simply getting Manisha to elevate her arm. We need to assess whether this has been successful. To do so, we check that the bleeding has stopped, and we can also check the radial pulse.
Okay, so Grace, you're doing a great job. Just continue, please. So I'm going to, while Grace is holding the head in place, I will slide the collar underneath the patient's neck and wrap it around underneath their jaw and lock that in place. So that I can compare these. I want to next gain a history, both a medical history as well as what's happened here now. I want to use plus discs to assess the suspected fracture. First, I want to check for a pain score out of 10, and my patient has indicated an 8 out of 10. So I want to first deal with this pain before I assess this any further. For this, I'm going to use methoxyfluorine, which is an inhaled analgesic. The indications for use are moderate to severe pain, and the contraindications are any known renal impairment, allergy to this, family or personal history of malignant hyperthermia. I'm going to use triangle bandages to secure the splint. So I'm going to prepare this in advance to limit the movement of the leg. Thank you. And then I'm going to
secure this in place with my travel bandages, ensuring this is nice and tight to immobilise and secure the leg. I'm tying on either side of the wound, ensuring I don't cover the wound and secure it well. Okay, after doing this, I'm going to reassess cardiovascular and neurological integrity and reassess my patient's pains.
Five, four, three, two, one. Chest rise. Chest rise. Continue. Ten, nine, 8, 7, 6, 5, 4, 3, 2, 1. Chest rise. Chest rise.
Okay, so Hannah, when the machine starts to analyse again, we're going to swap places, and I want you to go around past the patient's feet.
Yep. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. No chest rise. Chest rise.
Placing a towel underneath the patient's head will help keep the airway open.
Ten, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Stop CPR.
Stand clear. That way.
Analyzing heart rhythm. Stay clear of patient.
If it requires a shock, I want you to push the
Analyzing
shock.
heart rhythm. No shock advised. Pause.
Okay.
If needed, start CPR.